Bismillah ar-Rahman ar-Rahim. Good evening, everyone. It's my pleasure to present the state-of-art lecture in this prestigious meeting. I'm going to talk about contemporary management of heart failure. We know that heart failure is an epidemic disease all over the world. 1 to 2% of the general population have heart failure. The disease which is characterized by high incidence of mortality and recurrent hospitalization. So if we look for this slide, we can see how the heart failure is a serious disease. Once diagnosed, as long as patients have heart failure, the mortality is high. And we can see from this important data from a study involved more than 55,000 in UK, aging above the 45 years with the new diagnosis of heart failure. We can see that the 1 year survival is high, 70%, and with the 5 years, within 5 years, the mortality reach up to 40%, and 10 years, the mortality is 20%. So we are dealing with a progressive disease, disease which increase the mortality over years. We know from the 2016 ESC guidelines that heart failure can be classified into heart failure with reduced ejection fraction, when the ejection fraction is below 40% with symptoms and signs of heart failure, and heart failure with mid-range ejection fraction 40 to 49%, symptoms and signs of heart failure with high level of natriuretic peptides and at least one additional criteria, such as structural heart disease, left ventricular hypertrophy, left atrial enlargement, evidence of diastolic dysfunction. On the contrary, patients who have heart failure with preserved ejection fraction, the same criteria as mid-range ejection fraction, but when the ejection fraction is 50% or more. This was known as HFpEF, or heart failure with preserved ejection fraction. Recently, 1 month ago, I had the pleasure to be one of the co-authors of this new universal definition and classification of heart failure, involving the Japanese, American, and European experts in heart failure all over the world. What this universal definition means? Heart failure is defined as symptoms and or signs of heart failure caused by structural and or functional cardiac abnormality and corroborated by at least one of the following criteria: elevated natriuretic peptides or objective evidence of cardiogenic pulmonary or systemic congestion. So this is the new definition for heart failure. And a new classification for heart failure compared with heart failure with reduced ejection fraction, mid-range ejection fraction, preserved ejection fraction, 2016. Now we have heart failure with reduced ejection fraction, the same as before, less than 40%. Not known now as mid-range, heart failure with mildly reduced ejection fraction, 41 to 49%. Preserved ejection fraction, the same definition, EF, 50% or more. And look for the new phenotype, heart failure with improved ejection fraction. Heart failure with baseline ejection fraction was less than 40%, but now improved. 10-point increase from the baseline, and then a second measurements will be consistently above 40%. So this is a new definition, new phenotype, which can be seen in the daily practice. You are treating patient with baseline ejection fraction with around 35%. And then he improved with the treatment, ejection fraction with the new therapies. Now the ejection fraction is 46%, 45%. So this is known as heart failure with improved ejection fraction. We know that heart failure is associated with neurohormonal activation, early compensatory mechanism, activation of the renin-angiotensin-aldosterone system, activation of the sympathetic system, arginine vasopressin system. All these compensatory mechanisms initially are beneficial to maintain the cardiac output and blood pressure. However, with time, this compensatory mechanism is deleterious because salt water retention, increased filling pressure, increased pulmonary and systemic congestion symptoms, and vasoconstriction, increased systemic vascular resistance, decreased forward stroke volume, decreased cardiac output, and the vicious cycle will continue. So this is slide which summarizes the pathophysiology which is seen in patients with heart failure. What are the goals of treatment patients with heart failure? We are giving treatment to improve survival, definitely, to reduce mortality, and to reduce hospitalization, hospital admission, which represented the main burden for the healthcare costs, recurrent hospitalization. And definitely, we need to improve symptoms, quality of life, so make people feel better. This is a very important target for any modality of treatment. So to do that, we have to work on this pathophysiology, the targets. We have to counteract the RAS system. So we have ACE, ARBs, RNA, antagonists. We have to tackle the sympathetic nervous system. So we have beta blockers. For natriuretic peptides, we have RNA, as we will discuss later. Heart rate should be slowed. So we have beta blocker and ivabradine. Combination of hydralazine azorubide nitrate combination. Sudden death represents 50% of mortality in patients with heart failure. So we have to abort sudden death by ICD. And patients who have wide QRS and electrical and or mechanical dysynchrony are considered good candidates for cardiac resynchronization therapy, a modality of treatment which improves quality of life, symptoms, and decrease mortality. Congestion can be treated with diuretics only and exercise for compensated patients. So key points, just key points for every line of treatment very quickly. Diuretics in heart failure relieve symptoms of congestion. However, they activate the sympathetic system, renin-angiotensin system, so we have to use the lowest dose possible to maintain evolemia. Don't do aggressive hypovolemia because this is deleterious for patients with heart failure. It does not improve mortality, as we said. And we have to expect diuretic resistance with time. Initially, good response to diuretics, and with time, not good response, due to several reasons for diuretic resistance. But we can treat this diuretic resistance by combination of metolazone, etc., etc. Don't forget concomitant sodium restriction. 3 drugs are considered class 1A recommendation for heart failure. Any patients with heart failure should be given ACE inhibitor, beta blocker, mineralocorticoid receptor antagonist MRA, drugs which have been proved to improve survival and decrease hospitalization according to many landmark studies over years. And this slide summarizes the benefit of these drugs. ARBs, angiotensin receptor blockers, decrease mortality by 12%, ACE inhibitor 16%, beta blockers, relative risk reduction in CBS2, MERIT, and Copernicus heart failure trial using bisoprolol, metoprolol, and carvedilol by around 34%. And the mineralocorticoid receptor antagonists, either spironolactone in REAL study or eplerenone in emphasis heart failure study, proved that it can decrease mortality by around 30%. ACE inhibitors improve symptoms, clinical status, exercise capacity, improve cardiac function, reduce hospitalization, attenuate remodeling, prolong survival, and reduce vascular events. The take-home points regarding the use of ACE inhibitors should be given for any patients with EF less than 40%, all NIHA classes, use target doses, titration to reach the maximum tolerated dose, intolerance due to cardiorenal limitation with the rising of serum creatinine and the potassium carry a poor prognosis. Cough and angioedema are common. Increasing creatinine up to 0.5 milligram per deciliter is expected, and most studies have excluded patients with creatinine above 2.5 milligram per deciliter. Beta blockers have a beneficial effect because it leads to upregulation of beta receptors, decrease myocardial oxygen requirements. It has an anti-arrhythmic effect, improve myocardial relaxation, slowing the heart rate, protection against the circulating catecholamines, reduction in incidence coronary events, correct the overactive RAS system. So, according to these studies, the benefit regarding mortality reduction with the use of beta blockers have been proved. So, in the daily practice, you have to give beta blockers for patients symptomatic or asymptomatic heart failure with ejection fraction less than 40%. Titrate, start low, go slow, keep eyes on blood pressure and heart rate to avoid hypotension and bradycardia. Titration every 2 to 4 weeks. Adjust other treatments. If the patients become more congested, you have to increase the dose of diuretics. Can be stopped only if the patient presenting with hypotension, hypoperfusion, and patients who needs inotropes. Mineralocorticoid receptor antagonists should be given in patients with heart failure with EF less than 40%. Potassium renal function should be monitored, of course, because rise of serum creatinine and potassium can occur, especially in predisposed patients, elderly patients, if diabetic patients, baseline serum creatinine is high. So you have to be very cautiously with the use of mineralocorticoid receptor antagonists. We have sacubitril valsartan combination, which is ARNI. What is the rationale for using this combination, sacubitril valsartan or Entresto? The endogenous vasoactive peptides like ANP, PNP, natriuretic peptides, adrenomedallin, bradykinin, substance P, calcitonin gene-related peptide, undergo degradation into inactive metabolites through neprilysin. So neprilysin inhibition will preserve these vasoactive peptides, which have a benefit in terms of decreased neurohormonal activation, decreased vascular tone, decreased cardiac fibrosis, hypertrophy, sodium retention. And neprilysin also is responsible for degradation of angiotensin II. So we have to combine valsartan to block the AT1 receptors, angiotensin receptor blocker. So we are using neprilysin with neprilysin inhibitor, sacubitril, valsartan to block the AT1 receptors. So this is the paradigm heart failure trial. 8,000 patients with heart failure, function class 2 to 4, comparing sacubitril valsartan, titrating the dose up to the maximum dose, 200 milligram PID, compared with enalapril, which is the cornerstone ACE inhibitor for treating heart failure patients. And if we look for the composite primary endpoint in terms of cardiovascular death and heart failure hospitalization, we can see that 20% relative risk reduction, a study which was prematurely terminated after 27 months due to the overwhelming benefit of sacubitril valsartan in reduction of the primary endpoint. And interestingly, sacubitril valsartan was associated with significant reduction in all modalities of death. All-cause death, cardiovascular cause of death, sudden death, which is 50% in heart failure, and death due to pump failure or worsening heart failure decreased significantly. So the guidelines 2016 considered that sacubitril valsartan is class 1B recommendation in patients already on ACE inhibitor and still symptomatic. So you have to replace ACE inhibitor with sacubitril valsartan. And ivabradine, which is an IF current inhibitor, a drug which acts selectively on the SE node to decrease the heart rate in patients who have heart rate more than 70 beats per minute, in spite using an adequate doses of beta blockers. So a class 2 recommendation to add ivabradine based on the SHIFT trial, which revealed that the use of ivabradine in heart failure patients, function class 2 to 4, was associated with significant reduction in cardiovascular death and heart failure hospitalization. So we need to slow the heart rate in patients with heart failure, and if the patient is not a good candidate for beta blocker due to bronchospasm, COPD advanced, so we have the choice to give him ivabradine instead of beta blocker. Prevention of sudden death by implanting ICD. Second, prevention for patients who arrested and resuscitated or have serious ventricular arrhythmias. Or primary prevention in patients with an EF less than 35%, despite treatment with optimal medical treatment. It's considered a class 1A in ischemic cardiomyopathy, class 1B in dilated cardiomyopathy. So this is an algorithm for management of patients with heart failure according to the EC guidelines. That symptomatic treatment for congestion by using diuretics, ACE inhibitor, beta blocker. If the patient is still symptomatic, you have to add mineralocorticoid receptor antagonist. If the patient is still symptomatic, replace ACE or ARBs by sacubitril valsartan. If the heart rate more than 70, adding ivabradine. If the patient has a QRS more than 130 milliseconds, so implanting ICD is important. Class 2B recommendation, other drugs like digoxin, for example. And don't forget prevention of sudden death, either primary or secondary. Now we are in the era of new drug classes, new drug classes which are considered a novel drugs in patients with heart failure based on a landmark trials. Sodium glucose co-transporter inhibitor, SGL2 inhibitor. Many mechanisms have been suggested for the benefit of SGL2 inhibitor in patients with heart failure. Drugs which act at the proximal convoluted tubules to decrease reabsorption of glucose, leading to glycosuria, natriuresis, and it improves kidney function and the cardiorenal physiology, decrease preload, afterload, and reduction in LV wall stress, reduction in interstitial edema. So many mechanisms have been described for the benefit. So DABA-HF trial, a study which was based on the rationale for the testing the superiority of DABA SGL2 inhibitor compared to standard of treatment in patients with symptomatic chronic heart failure with reduced ejection fraction with or without diabetes. So a study which involved more than 4,700 patients, EF less than 40%, high level of natriuretic peptides, compared with the usual or standard of care. If we look for the primary endpoint, cardiovascular death or worsening heart failure event, compared with the placebo, the use of dapagliflozin in heart failure patients was associated with the significant reduction in the primary endpoint, cardiovascular death or heart failure hospitalization or any urgent heart failure visit. Number needed to treat was 21, the same as sacubitril valsartan in paradigm study, and the relative risk reduction was around 26%. So if we look for the worsening heart failure event, which is one component of the primary endpoint, it decreased significantly by around 30% compared with placebo, very highly significant p-value. And if we look for cardiovascular death or heart failure, this is the same slide before. If we look for the cardiovascular death, 18% relative risk reduction, which was also statistically significant. And interestingly, for all patients, the benefit of DABA compared with placebo is very clear. But if you look for patients who are diabetic or non-diabetic, the benefit is the same. Regardless the patient is diabetic or non-diabetic, the use of dapagliflozin in heart failure with an ejection fraction less than 40% function class 2 to 4 was associated with significant reduction of the same primary endpoint, either in the presence or absence of diabetes. The secondary endpoints decreased by 25%. What about the safety? The safety has been improved compared with the placebo. No risk for diabetic ketoacidosis, major hypoglycemia, etc., etc. But if we look for any serious adverse events, it was significantly lower with the use of DABA compared with placebo. So the drug is safe to be given in heart failure, even if the patient is non-diabetic. And another study, which is an impero-reduced, it was based on the same rationale for SGL2 inhibitor in heart failure, 10 milligram impact compared with placebo, looking for the primary endpoint, composite primary endpoint, which is the time to first event of adjudicated cardiovascular death or heart failure hospitalization. Secondary endpoints, first and recurrent heart failure hospitalization, And interestingly, they looked specifically for the renoprotective effect for SGLT2 inhibitor in patients with heart failure. And it's very important in heart failure patients to give a drug which has a renoprotective effect, because renal dysfunction is common in heart failure. Around 60% of patients with heart failure have renal dysfunction. So to give drugs to treat heart failure with a benefit on the renal function, this is very important. And this class has a renoprotective effect which appears significantly after 2 weeks of initiation of this treatment. So the same benefit, IMPA compared with placebo, relative risk reduction 25%, absolute risk reduction 5.2%, number needed to treat very low, 19 patients, and 30% relative risk reduction in hospitalization for heart failure. And this interesting slide shows the renoprotective effect compared with the placebo. Every year there is a drop in the estimated GFR compared with EMBA every year, 0.5 milli reduction. So the difference is 1.7 in favor for empagliflozin. So this proved that the use of EMBA is associated with a renoprotective effect. Nowadays, we have many interesting data which started to support the benefit and to explain the benefit of this group of drugs in heart failure patients. What about the effect on remodeling, LV function, end systolic and end diastolic volume index? So this slide summarizes that the use of IMBA was associated with favorable effect on parameters of LV remodeling, reversing remodeling by reduction in end diastolic volume, end systolic volume index, and the increase in ejection fraction. And this is very interesting. And this is a study which proved the benefit of IMBA in IMBA tropism study, that the use of empagliflozin in heart failure patients, diabetic or non-diabetic, has the benefit of reversing LV remodeling and the improved LV function. The last study regarding SGLT2 inhibitor in heart failure, the SOLICIT worsening heart failure, sotagliflozin in type 2 diabetes and worsening heart failure. So those are more advanced heart failure patients, more hospitalization, and the benefit in terms of reduction of total cardiovascular death, heart failure hospitalization, and the urgent heart failure visit also was in favor for the SGLT2 inhibitor SOLICIT, sotagliflozin, compared with placebo. So the final 2 slides. This is the foundational therapy in heart failure now. Sacubitril, valsartan, MRA, beta blocker, SGLT2 inhibitor, and consideration when you have to give these drugs. And finally, this is the Fantastic Four. This is the take-home message of this presentation. The take-home message of the presentation says that patients with heart failure should be given the 4 drugs. Should be given ARNI, should be given beta blocker, should be given MRA, should be given SGLT2 inhibitor. This is the Fantastic Four. These drugs which improve survival and decrease hospitalization for heart failure patients. Thank you very much for your attention.